Lymphoma Voices podcast brings you a series of conversations around topics of interest for people affected by lymphoma, the most common blood cancer in the UK.
Hello, in this podcast we're going to talk about fatigue. My name is Anne Hook and I'm the Publications Manager at Lymphoma Action. And I'm delighted to be joined today by Ruth Jackson. Ruth is a Haematology Nurse Clinician at Mersey and West Lancashire teaching hospitals. Hello, Ruth.
Hi, Anne. Thanks for having me.
Ruth, can we start by trying to describe fatigue? What is it? And how would you describe it in comparison with just feeling tired?
Yeah, that's a good question. And I think, this is something that pops up for me every day in my clinical practice. I think it often means different things to different people, perhaps in the same way that pain, we all react differently to that. But fatigue, I would describe it as an overwhelming tiredness. It's a tiredness that isn't relieved by, having a good night's sleep. Day to day, I might go to work and feel tired, and hopefully I go home, put my feet up, have a good night's sleep, and then I feel refreshed the next day. But I think with fatigue, I think it's a constant battle for our patients. Low energy, it might affect mood, it might affect sleep pattern, and therefore our patients don't have that luxury of being able to rest or sleep and feel better the next day, really. So yeah, I would say it's more than your average tiredness. It's an overwhelming feeling that really can sort of impact on one's activities of daily living and be quite debilitating, actually.
And can I ask you, what causes fatigue in someone with lymphoma? Do you think it's the cancer or the treatment or both?
Yeah, I think both for sure. We know that patients with lymphoma or other cancers, if you like, we know the disease burden does cause fatigue. And sometimes that can be because of the dynamics of the cancer and that rapid turnover of cells. And actually, you're using a lot of energy. But I would say probably more than 70%, and I think this is documented, that probably more than 70% of lymphoma patients will describe fatigue. And then if we add in things like chemotherapy, radiotherapy to that, then that will increase the fatigue. Bear in mind that I think lymphoma and other cancers, predominantly they are diseases of older age. So actually, as we get older, we might have other health problems. A lot of my patients might have heart failure, COPD, diabetes. And actually, if we think about the mechanism of diabetes and the fatigue that you get with that. And then I think if we add in medications that our patients might be taking. So yes, they might be having medications for the cancer, for the lymphoma, but actually medications that they may take for osteoarthritis, they might be on pain relievers. So I definitely think it's multifactorial, definitely as a result of the disease itself, but there's so many factors that affect fatigue. And I think if you really sort of sit down and make a list, there's probably many, many things. Hormonal imbalances. Met a patient not that long ago, and he'd actually got lymphoma, but he also had prostate cancer. So was on treatment for that, which involved hormone treatment. And it's really difficult to unpick what is causing the fatigue. Is it the lymphoma? Is it his prostate cancer? Is it his treatment? And that would probably be true for a lot of my patients, really trying to unpick what is driving the fatigue. And I think often it's more than one issue.
So would something like diabetes or thyroid issues, would that play into that as well, do you think?
If I'm meeting a patient in the clinical setting, I can guarantee fatigue would come up in most of my consultations. And I think it's really important to think, are we managing your other chronic illnesses? And that's often where we need to have good links with primary care, GPs, practice nurses. I think a lot of our patients, their expectations often when they come to hospital is that we can fix everything. But actually, I think it's acknowledging why the patient might be fatigued, but then think of the other things as well. And sometimes that is encouraging the patient to reach out to the GP, making sure they're keeping up with the medication reviews, diabetes checks, effects, having thyroid function. Could be a patient that might have had radiotherapy to the neck, and actually, although they've not previously had thyroid dysfunction, they may go on to develop it as a late effect of the cancer treatment. So I do think in the clinical setting, we need to really be thinking out of the box, because sometimes it's so easy just to say, oh, yeah, lymphoma causes fatigue or chemotherapy causes fatigue. I think we really need to be thinking, what are these patients at risk for? Have we screened for other conditions? Are these conditions being managed? So that is really where we need to have good working relationships with primary care as well to help support our patients.
Can I ask about the role of the GP and something like fatigue?
I think it is important to have that link with the GP. I think my experience is patients think we're the fixer of everything sometimes in the hospital because they might have easy access to us. And we do encourage our patients to make contact and let us know of anything new. But I think it can be difficult to get an appointment these days with GPs. So, a lot of my patients might say, oh, well, I'm mentioning that here because I didn't want to book an appointment with my GP. But I think it is really important because the danger is we can blame the lymphoma for everything. You can get so siloed and blinkered and focused on the lymphoma that actually, could there be something new going on? Could we have a new diagnosis of diabetes, thyroid dysfunction, other things that can cause fatigue? So it is really, really important to have that chat with the GP so they can run diagnostics, blood tests. And actually there might be this sort of psychological support that's needed. So GPs can often refer to things like talking therapies. So yeah, I think it's important. I always encourage my patients at their appointments, a lot of patients might say, oh, I've got fatigue, but you can't do anything about that. But I also know it's important that we know about it because we need to know what level of fatigue you've got. How is it impacting on you day to day? Because, it's our job to unpick, is this the lymphoma or is this something else? I think the important thing as well to think about is, I usually talk a lot to my patients about prehab. We always think about rehab after treatment, don't we, and managing late effects. But for those patients that have not yet needed to start treatment, we want to optimise them in case there comes a time when they do need treatment. So it is having those good links with the GP, making sure our patients keep up with the blood check. It could be a blood pressure check. So actually we're making sure they are in tip-top condition. So when the time comes that they do need to have some form of treatment, that we're not going to have a barrier whereby they might have developed, high blood pressure or something like that. So again, it's all about health promotion, isn't it? And this is where we do really rely on our primary care colleagues for help. So yes, GPs are definitely important with fatigue management and that whole sort of prehab notion of optimising yourself before treatment might be required.
Can fatigue actually be diagnosed?
I would say there's no specific test. I mean, we might have scoring scales where we can ask a patient to rate their fatigue, but there's not necessarily a diagnostic test. So, for example, if someone's anemic, we can diagnose that on the blood. We can pick up lymphoma on a scan, but there's no sort of measurable diagnostic for fatigue. So it is very much that in the clinic setting, being guided by the patient's experience, their story, what they're telling us. And I think sometimes the patients are often surprised when I might relate that back and say, oh, I think you're experiencing fatigue, and there's lots of reasons for that. Again, sort of something that resonated recently with me was I met with one of my patients in clinic and he came in with his wife. She was saying, oh, he's driving me mad. He's got no interest. He's not wanting to do things. And I've got jobs around the house. And actually we sort of unpicked that, yes, he's got lymphoma. Yes, he's currently on treatment for that. And they both just hadn't joined the dots, actually, that this was sort of chronic fatigue and how it was impacting on both of their lives day to day. He felt almost a bit of a failure, really, because he couldn't be bothered to do specific tasks. and the wife was a bit, frustrated because she felt like he should be doing more. So actually, when we sat down and said, well, actually, there's lots of reasons here why you might be fatigued, your diagnosis, its treatment, etc., I could see that there was a bit of a light bulb moment for both of them. And actually, this patient's wife said to me, she went, I think I've been very harsh on him. It's difficult, isn't it? Because as loved ones, partners, we want to encourage, and that's really important, isn't it? Is to have someone behind you motivating you. But actually, I think that was a light bulb moment. So, that wasn't necessarily me doing any diagnostics, but I think it's that communication, isn't it? It's unpicking, it's taking a bit of a history, talk me through, when do you feel more tired, and is there anything that makes it better or worse? And so I would say it's more something that we diagnose through taking a good history rather than a specific test.
And how long, Ruth, do you think fatigue is likely to last for someone?
I think that's variable. So we know, for example, patients who might have a lot of disease burden from the lymphoma. So, for example, someone that might present with a high-grade lymphoma, we know they're going to be burning over a lot of energy, and they might be losing a lot of weight because of their disease. My experience is that often when we start to treat patients that are really unwell as a result of their lymphoma, that overall, even though we're giving them drugs that can cause fatigue, things do improve and our patients get back to a reasonable quality of life. So I think it's very interchangeable depending on what is going on with the lymphoma, with the disease itself, what is happening from a treatment point of view. Now, I'm aware that actually some of our patients don't need treatment and they might be on observation only, but actually still experience some fatigue. I think it's always important to think what else is going on, as we've already said, with other conditions. So I think it's very changeable from person to person, depending on where they're at in the disease journey and what other comorbidities they might have as well. I think sometimes the thing that can help is that discussion of acknowledging someone has fatigue and then actually thinking about, well, how can we manage this? I think it's almost having permission, isn't it, from someone else to say, well, yeah, there is a reason why you're feeling like this. And again, it's that light bulb moment, which might help you to think, well, how can we manage it? It might never go away for some people. But yeah, I think that's very different from person to person.
We've been talking about treatment, and can I ask about radiotherapy? Can radiotherapy cause fatigue?
Absolutely. Any of our anti-cancer treatments, I think the first go-to everybody thinks about is chemotherapy causing fatigue. But yes, radiotherapy, some of our other treatments like immunotherapy, monoclonal antibodies, it's well documented that these things can cause fatigue. In particular, with radiotherapy, sometimes our patients can be going daily for treatment for a number of weeks. I get patients say, oh, you're only on the machine for a few minutes, but actually that does start to take its toll. We're still getting rid of that active cancer. It is toxic, and it does have sort of an accumulative effect. So again, it's managing expectations to say, although, in the early days of your radiotherapy, you might not feel too bad, but then by the time you've had maybe 2 or 3 weeks of radiotherapy, numerous trips to the hospital, sometimes depending on what area of the body, you're treating with radiotherapy, you might start to encounter some side effects. Common area that my patients might be treated is to the neck. And as a result of that, they might get sore mouth, which then that might impact on the oral intake. So they're not getting the calories in that they should do, struggling to drink and things like that. So I think it's not surprising when you think about the areas that we're treating and why that then in turn might impact on fatigue.
Ruth, you've talked about treatment and you've touched on people who are being monitored. A lot of people we speak to are on active monitoring and can be on active monitoring for a very long time. Is the fatigue also likely to be long-term?
I think that's variable from patient to patient, really. And I think it depends on the individual's coping strategies sometimes. And as we know, with even lymphomas that don't require treatment, there might be times when the lymphoma is more active than not. So I think there might always be a little bit of fatigue, but then it's how that individual manages that. So actually they may find with some strategies that they've developed that it actually improves. So I think it's not a one size fits all. So again, I think it's that managing expectation that it may come and go throughout your time with lymphoma. Bear in mind, a lot of our low-grade lymphomas, this is a condition that they're going to live with lifelong, in the same way that someone with diabetes is going to live with that condition lifelong. And I think it's not to take away from our patients that are on active monitoring. They often feel like, well, I'm not on treatment, so why am I feeling like this? And I think employers, family, friends, they might also have that same ignorance, really, where they think, well, they're not on treatment, so it can't be that bad. So I think, again, with education and informing our patients that actually you've still got active cancer, although it's not needing treatment at the moment, there is still a good enough reason why you might be fatigued. It might not always be like this, because invariably you're going to develop some strategies to improve the fatigue. So, yeah.
And I want to touch on some of these strategies to help with fatigue. The first one I was going to mention is, should I push through the fatigue or should I rest? Is it good to have a nap during the day? What are your thoughts on what approach is the best for people?
I think when I'm chatting with my patients, I want to sort of get an understanding of what their routine is, what are they doing. I might have some patients who feel the need to function normally, proving a point, you're Superman or Superwoman and you can do all of this. And again, I think it's important for us to give that permission that it's okay to rest when you need to. I always encourage my patients to try to be active. That's really important. But, and I think when I'm saying that, they might think, oh gosh, she's trying to sign me up to the gym here. And it's not about that. It's about just some activity. But I think that whole concept of pushing through, we need to be careful, because there's sort of something called the boom and bust model. Patients might feel really, really well one day and they're all in, boom. They want to do everything. But actually, the consequence of that is the bust the next day, where they crash and then actually they feel dreadful. So you can sort of quite easily get tied up in this boom and bust cycle. So therefore, it's not always helpful to push through. I think it's about setting goals, prioritising what is important day to day. It might be that you've got a particular job to do in the house. Rather than cleaning the whole house in one day, can we just do one room at a time? Can we make it more manageable? And then we're not going to sort of have that boom and bust, and we're going to struggle where tomorrow we might not be able to do anything. So actually it's better to take bite-sized chunks, isn't it, and do some household chores one room at a time rather than doing everything in one day. So yeah, I think it's trying to not push through too much. And I think listening to your body is key. Resting when you need to. I think we're not good, I think, as a society, at sort of just thinking, I'm just going to chill out and have a cup of tea and put my feet up for 10 minutes. I think there's always this burning desire to be on the go and doing something. And just that permission is so important. Planning, prioritising is really important. I might have some patients who they've got a particular event coming up, and that could be like a family function, and they're really dreading it because they know the fatigue might make it difficult to get to that function. So it's about thinking, well, what can we do to conserve energy? And, we don't always need to push through it. If that's your goal for the week, then save your energy for a few days and, then you can go and enjoy that special occasion.
A lot of people ask, is it a good thing to have a nap in the day, or is that counterproductive? What's your thought on that?
Yeah, I think I try to get my patients to have a good routine and avoid cat naps. So when I'm saying about resting and putting feet up, I don't mean then nodding off and you've had 2 hours afternoon nap, because actually is what you find then is come the evening, you might not be able to settle down quite as easy. So I think it's having a good daily routine. Sleep hygiene is really, really important. I might say to my patients who come into clinic with their family members, because the family members say, they're always nodding off on the couch, and and I'm a bit like, well, poke them. It's like poking the baby, isn't it? Because you want to keep the baby awake, then they'll sleep at night. So I'm a bit ruthless, really. I sort of encourage my patients to, although rest, don't be having a 2-hour snooze on the couch, because actually that might be counterproductive of an evening. Some of my patients might find it difficult to unwind at bedtime anyway. And I think especially if they're going through a difficult time, new diagnosis or relapsed lymphoma, that actually often for some of my patients, the nighttime is the worst, because that might be when they go to bed and the brain, is active and they're thinking about all of these things. So I always want to encourage good sleep hygiene, maybe having a little bit of wind down, avoiding things like screen time, trying to find an activity that might help you to relax, whether that's reading a chapter of a book before bed, having a wind down with a milky drink, even things like mindfulness, meditation. All of these things can be very helpful as well. So it's just trying to get into that good routine, getting 7 to 8 hours sleep. Wouldn't that be marvellous? We know what to aim for, but in reality that doesn't always happen, but especially if your mind's very active. So I personally encourage my patients to try and stay awake in the day and get the family to poke them and say, come on, wake up. But that's where activity is good, isn't it? Getting out for a little bit of a walk, getting those endorphins going. So I think routine, is key.
You've touched on exercise there. Of course, when you're tired, the last thing you think wanting to do is let's go out for a walk. But from what we hear, when you do, it makes quite an impact on your fatigue. Is that what you find when speaking to your patients?
Absolutely. We talk about exercise to our patients. We want to encourage some kind of activity. And I think that is me saying to the patients, I'm not expecting you to go running on a treadmill. If you've never been able to do that before, then why would I want you to do that now? It might be something simple like going to the newsagents down the road to get a newspaper, or if you've got a dog, getting the dog out, things like that. So it's just a walk, isn't it? Getting that dopamine release when you put the sun on your face, having those endorphins. But it's difficult, isn't it? Because I've got patients that are saying, I can't be bothered. It becomes a vicious cycle. So again, I think this is where planning is key, trying to set that routine to think, no, it's midday now, I need to get out and go for a walk maybe. And that might be something as small as a 15-minute, 30-minute walk. I do always remind my patients when they're going out for a walk that they need to bear in mind that they need to get back. So if you're really struggling with things like mobility and becoming tired easily, bear in mind how far you walk out, you've got to walk back. So it might be a simple task for someone. Some of my patients do still go to the gym or might go swimming because they're very fitness focused and they want to keep that energy up. But for some of my other patients, actually just going for that 15-minute walk is a big deal. So I think, again, it's that permission, isn't it? Not beating yourself with a big stick if you're not able to do that. Having family that will encourage and say, right, come on, let's get our coats on, let's get out. So, yeah, I think exercise is really, really important.
And does diet have a place in this? Does what you eat affect how fatigued you are or not?
I would say for sure it does. One of the biggest things I find with my patients is they might say they've got no appetite, particularly during a time where the cancer is active, or they might be on treatment. I've already alluded to the fact that, someone with active lymphoma, active cancer may burn more calories than I do, for example. So nutrition is really, really important. And that can be quite challenging when you've not got an appetite or you're feeling nauseous. So again, it's the bigger picture, isn't it? And thinking, if you're nauseous because of your treatment, speak to your team. They might be able to help with things like anti-sickness so that then you can get food in and get the right nutrients. We know that we get essential vitamins from food, things like B vitamins, iron, folate. These are all the building blocks for our blood, for our red cells. We often think of anemia, don't we, when we think of fatigue. So nutrition and diet plays a vital part in everything, from us having enough calories to function, to burn enough energy. It really is that old adage, isn't it? You are what you eat. And I think if you're just having sort of empty calories every day, that's not got that nutritional element in it. It might not be surprising that I've got someone in front of me in clinic who hasn't got a good diet, but then they're coming into me and they're iron deficient or they're B12 deficient. So I think that said, it's difficult. Again, if I've got a patient on chemotherapy and the taste buds change or their appetite changes, I might encourage things that are not necessarily the healthiest. If they're enjoying a nice ice cream with a bit of cake, then go for it. But yeah, absolutely, diet is so important. And I think if that is something that you unpick as part of a contributing factor to fatigue, then for us as health professionals, it might be something simple like getting a dietitian on board. Education, even, sometimes I meet patients who might have never had the best of diets pre-diagnosis anyway. So sometimes it is just that sort of learning, education, without wanting to teach grandma how to suck eggs,
Yeah. And you talked about things like iron, B12 and so on. What are your thoughts about supplements? Do they help? Is there a place for them in this scenario?
I would always advise patients to sort of discuss that with either the GP or us, rather than them going down the path of taking something that they might have bought online because they've seen it can help with fatigue. Often there's no evidence base in some of these things. So I think it's really important for our patients to have that discussion so that we know what they're taking. But I think one of the tests, if you like, one of the blood parameters that I would do is often B12, folate and ferritin, so looking at iron content. I always say to my patients, well, let's have a little look at some of those essential vitamins, because it could be that you do need some replacement. And obviously we would definitely recommend that. Things like vitamin D, invariably we probably all don't get enough vitamin D because we don't get enough sunshine, do we? And then when the sun comes out, we put sunblock on. Low vitamin D levels can contribute to fatigue as well. But I would only be telling my patients to have replacement if they've got a proven deficiency in something.
Something that we hear that people use as a strategy is a fatigue diary. Is that something you've come across, and do you think it's a helpful addition for people?
Absolutely. It's hard to quantitate sometimes, isn't it? What fatigue means to an individual. It's understanding what their energy levels are like normally. It's trying to think, isn't it? Is there anything that is triggering the fatigue? What makes it better? What makes it worse? When are we most fatigued? Is there a pattern? Is it that we get a bit of a lull in the late afternoon or the evening? So I think if we've got a visual as to, when energy levels are dropping, that can be useful to our patients to plan and prioritise when they might be at the best. That is something that we do use quite a lot within our clinics, and we encourage patients to go away and do that.
And I just want to touch on working or studying. Are there strategies that people can develop to make it possible to return to work or to return to study, do you think?
I think it's, setting boundaries with our patients really, and managing expectations sometimes. A lot of my patients, when they might finish chemotherapy, for example, or radiotherapy, I think they expect to have had the last treatment and suddenly feel back to their old self. So I'm usually quite clear from the start. It can take many, many months for your energy levels to start to return. So therefore, it might be taking a little bit of extra time off work once treatment's completed. But then is what I would encourage a lot of my patients to do is have conversations with their employer. It might be that reasonable adjustments can be made, change to working hours, working patterns, flexibility, whether there's any sort of like working from home. So I think it's knowing your rights really as an employee when you're returning to work. Even my younger patients that might be in full-time education. I've had a few young lymphoma patients that were studying at university when they got their diagnosis. And it's just been completely unmanageable for them to carry on with the studies at that particular time. But again, it's having the conversation with their educational institution and us supporting that to say, can we put studies on hold? It might be for a period of 6 months or 12 months, things just get deferred. Or can we have an extension on deadlines? So I have provided support for patients, whether that be like a conversation with an employer or written letter, just to say, Mr. Smith has recently been through treatment or actually has a diagnosis of lymphoma. He might not be having treatment at the moment, but that's not to say that he's not still fatigued as a manifestation of the disease. Are there any reasonable adjustments that can be made? So I think it's really important to have those conversations, really.
You mentioned about knowing your rights. I mean, for a lot of people, it's quite a big jump to actually have that conversation. Is there anywhere that people can actually find details about what rights they have as somebody with lymphoma?
Yeah, one of the places in particular that I used to signpost, I mean, obviously our amazing charities like Lymphoma Action, Citizens Advice, there's a wealth of information there. Not all employers are understanding when I've had some patients go through some real difficult times with their employers. So from my experience, I know things like Citizens Advice have been really, really helpful. Carers support as well, because it's actually thinking about family members as well, because, you know, it's what rights they've got as carers and how their own work might be impacted because they're trying to care for the wife or the husband who's undergoing treatment at the moment.
I also wanted to touch on the psychological aspect of having fatigue, particularly if it's long term, and people maybe having to adjust to a new normal and not maybe getting straight back to how they were before their treatment. What are your thoughts on that? Does it have quite a big impact on the people that you see?
Absolutely. Psychologically, I think it's that wanting to continue and be normal, isn't it? When actually that might be unachievable, whatever normal is, or accepting a new normal. That can lead to a lot of anger, frustration. I've seen it affect people's mood, you know, to a point where it can cause anxiety, depression. So I think it's, again, really good to have these conversations and try to link our lymphoma patients in with support. I mean, we're very lucky where I work, but I appreciate not everyone has the same services in their areas, but we have a really good counselling service attached to our unit. And sometimes it is simple things like a counselling referral, conversations with GP as well about managing mood and how it might be manifesting.
Would you say it's very important for people to tell people around them, whether it's family or work colleagues or friends, about their fatigue? And how can they describe that? Do you have any tips on how people can tell family and friends that they're struggling with fatigue?
Yeah, I think it's a difficult one, isn't it? Because, you know, I meet some of my patients and it's almost like they want to carry on as normal and they want to have this bravado, if you like, that there's nothing wrong. So I think as a health professional, it's really important to say it's okay to admit that there's a problem. And actually, it's really important to have someone you can talk to about the fatigue. And I think it's trying to get colleagues and loved ones to understand that this is not just a day-to-day tiredness. It's very much like the couple that I mentioned earlier on in our chat. We've got the expectation from a loved one that you should still be doing what you were doing before your diagnosis or before your cancer treatment. I think it's trying to sort of explain that I wake up in the morning and I still feel just as tired as when I went to bed. And I think if you're sort of putting that out there, then I think whether it be an employer or a loved one or a colleague, I think they're going to be a little bit more accepting. You're not being lazy, you're not shirking work. It's actually because you're finding it very, very difficult. I think if we knew someone had a broken leg or a sprained ankle, I think we're often a bit more sympathetic, aren't we? Because we can see a plaster cast or we might see someone on crutches, and therefore we're going to think, well, yeah, we're not going to expect them to be running around or picking up extra jobs at work. But I think for fatigue, it's not seen, isn't it? So I think it is good to have those chats because people might not know what you're going through, what you're experiencing. Like mental health, isn't it? It's a hidden disability.
And we've heard about things like the 5 Ps or fatigue management. Have you come across them? And can you share a bit more information about them if you have?
Yeah, so the 5 Ps, again, there's lots of different versions, isn't there? I mean, I tend to use the 3, which is prioritising, planning and pacing, just because I think it's easy to remember 3. But then I think if we think of the extra ones on there, which is like permission, which I've talked about a lot today, positioning is another one. So it's about adjusting. If you're doing a particular task, whether that be something simple like ironing, you can't stand up to do your ironing, so you're just going to change your position and maybe get a seat or a perching stool. I like to use the 3 Ps. Prioritising, planning is a big one, pacing. If you get those 3 embedded as a tool, then the others are there to be added on. But yeah, I think they're really useful to get the patient to accept, really, that there is a model there that I can use. Yeah, I think that's a good tool.
I found it very interesting you talking about the 3 Ps. Can you just expand a little bit more on that?
Yeah, so I think number 1, prioritising. What's an important task? That, again, that's variable from person to person, isn't it? So prioritising might be something for a function that's coming up at the end of the week, a family event, or it might be prioritising a workload. So I think it's really important to think, what is my goal for today? What is important to me? What can wait? Okay, so we've got prioritising, we've got planning. Could I get someone else to do a task? And I think that's often difficult, isn't it? Asking for help sometimes, but do I need to be the one that does that task? And then sort of pacing, acknowledging that you might not be able to do a task as quickly as what you did it before. But actually, as a result of that, you're going to be saving your energy levels. You're going to be avoiding that whole boom and bust. If you just keep pushing through and pushing through, yeah, you might feel good because you've achieved, what you wanted to do, but actually you pay the price for it the next day. I think the sort of like the top 3 for me that I discuss with patients: prioritising, planning, pacing, really, really important.
Ruth, that's been incredibly insightful. And thank you very much for your time to talk about fatigue and strategies. That's been really, really valuable. We do have a couple of extra questions that we do ask everyone. And the first thing is, what motivates you to do your job?
Oh, that's interesting. I think it's the impact you don't often realise that you have. I think the thing that I enjoy about being a haematology nurse is I get to know my patients for a long time, because often it is a chronic disease, isn't it, lymphoma? Our patients might live with lymphoma for many, many years. And, it's a joy almost to think that you've been part of that journey with patients and tried to make life a little bit more bearable, I would think. So, yeah, I think it's the impact that we have on patients and their families. And that's what motivates me day to day, really.
Yeah, and it's huge from what we hear. And there's another one, which is, if there was one message you wanted to give to people with lymphoma, what would it be?
It would be to reach out for support. You're not in this alone, really. So whether that be with your hospital team or charities like yourself with Lymphoma Action, there's a wealth of information out there. No question is stupid. We might not always have all of the answers, but just ask for help from your hospital team or reach out to some of the cancer charities. And I think it's that sort of knowing you're not alone, really.
Ruth, it's been absolutely fantastic. Thank you very much for your time.
Oh, thank you for having me.
For more information about lymphoma and the support we can offer to people affected by the condition, please visit the Lymphoma Action website at www.lymphoma-action.org.uk. Lymphoma Action: inform, support, connect.